The silence is quiet, and it feels like it's getting hard to breathe. And I know you feel like dying, but I promise we would take the world to its feet. Move mountains, bring it to its feet. Move mountains, and I'll rise up, I'll rise like the day. I'll rise up, I'll rise unafraid. I'll rise up, and I'll do it 1,000 times again.
Good afternoon. You're tuned into Ability Matters, the program that covers matters to do with abilities, disabilities and everything in between. We are one of the longest running disability-related shows in the world, starting as Headway on air all the way back in 2007 and now brought to you by My Home Living Care, an NDIS registered disability support organisation.
Yes, thank you very much, Sean. I'm, of course, your host, Tony S. And with me, as per usual these days, is my co-host, Beck. How are you, Beck?
Good. How are you today, Tony?
I'm going pretty good, thank you, Beck. But who do we have with us in the studio today? Someone special?
We do. We've got someone on the other side of the fence that we don't usually hear about. We've got someone named Jacqui, and she's actually a researcher.
So she's behind the scenes stuff?
Yeah, so she's going to talk to us about the guidelines that come along for people that are going through rehabilitation and things like that. So she's going to explain a little bit more about the work they do and how it actually impacts on that. So how are you today, Jacqui?
I'm very well, Beck. Thanks for having me.
Bit of an issue there with the microphone, so okay, we'll fix it now. Go for it.
Excellent. Thank you so much for making some time out of I know you're a very busy lady, so thank you so much for coming along and having a chat with us. I suppose the first thing I'll ask you, if you could tell us a little bit about your current role and what you do.
Okay, so my current role is I'm an honorary research fellow with the Australasian Rehabilitation Outcomes Centre, which we'll call AROC for the rest of the interview because it's quite a mouthful.
Yes, so, AROC, that's good. AROC.
What AROC does, it's one of the outcomes centres that used to be housed under the Australian Health Services Research Institute, which is now housed under the University of Wollongong at the School of Medicine and Health.
Okay.
And some of the other outcome centres are, for example, the Palliative Care Outcomes Centre and the Chronic Pain Outcomes Centre. And what those centres do is collect data from all of the participating facilities, and then they produce routine reports for all of their members. One of the big strengths of AROC, for example, is that it's got close to 100% participation of private and public facilities across Australia.
Oh, wow.
And New Zealand.
Yeah, I was about to say, aren't they across the bank as well there?
Yeah. And what that means is that you've got a really sound data set because you've got everybody contributing. It's not just, for example, a very good rehab facility or one that doesn't get such great outcomes. It's got everything across the board. It also means that you've got a lot of data available. And AROC started in, I think it was 2002. It's just recently celebrated its 20th, I was going to say 20th wedding anniversary, 20th anniversary.
Yes, that was great lunch.
Yeah. And what that means is that there's now data, there's over 1 million episodes of rehab data on those episodes, which gives you a fantastic data set to work with. So AROC routinely produces reports for the member facilities. Biannually they get reports on how they're going. But it also collaborates with a whole range of clinicians and other people using that data set. So you can actually apply to AROC to use that data set.
Oh, wow.
Yeah, but there's a whole process to make sure that, the data's used with, properly and respectfully and ethically, because AROC is governed by ethics approval.
Ah, wow. Sounds like there's a lot of stuff happening behind the scenes. That no one really actually would probably even think about unless they were coming across it or something.
And this was brought to their attention, that's right. Which is kind of the hope of this interview.
Well, that's what I was thinking.
Yes.
We want to put a spotlight on all the work that actually goes in to make people's rehabilitation as seamless as possible. So I thought I would ask you as well, what motivated you to work in this field?
Okay, so I started out initially as a physiotherapist, and I worked as a physiotherapist for many, many years. But I started to also work with government agencies such as the Department of Veteran Affairs, Work Cover New South Wales, Motor Accidents New South Wales, that type of entity, using the data that they had to really look at the services that were being provided to people that are compensated under those schemes or managed under those schemes.
Yeah.
And then when I moved down here, the job at AROC came up, and it seemed like a really good fit for my particular skill set.
Oh, excellent. It sounds like it would have been probably perfect with all those background things that you'd been doing beforehand.
Well, I think one of the big strengths of the AROC model is you've got the statisticians and the data analysts, and it's actually a very, very small team for the enormous amount of output that they have, because they do thousands of reports a year. So there's not only the general reports and the national reports, but there's the impairment-specific reports as well too.
Oh.
And so there's a stroke impairment specific report, orthopaedic joint replacements, spinal cord injury, brain injury.
Wow.
And what's referred to as reconditioning, which of course is people that have become less functional through lack of use, basically.
Wow, it sounds like it's got a bit of a comprehensive approach, and there's a lot that actually goes into that.
So just jump in, that specific lack of use, that would be a direct result of the injury, I'm assuming?
Oh, it's often associated with older age groups.
Fair enough, yes.
Yeah, that particular cohort, which is actually quite a large percentage of the data, that's actually mostly older people.
Fair enough.
Yeah.
But is there anything where where you don't have to be old to get this condition, or is it only old?
That's right. You don't have to be old. You can just be incapacitated in some way. Say for example, well, if you had surgery or a medical condition, it doesn't take long for people to decondition, even if they're younger, fit athletes. If you're forced onto bed rest, even for a few days, when you get out of bed, you're kind of a bit wobbly.
Yes.
That is the beginning of your deconditioning, because you're not up and using your muscles.
Not active, I see.
Yeah,
yes.
yeah. And then what happens, of course, especially with people who gradually come into that situation because they're older, and then they start doing less, and because they're doing less, they start to lose more function, lose more muscle bulk. And then, of course, that becomes quite a vicious cycle. You're sitting down, and then you eventually find that getting out of the chair to go to the bathroom or the kitchen becomes about the limit of your day. So
they tend to get out of life fitness, yes?
Yes. Yeah.
Right.
Awesome. Well, I suppose we'll go to a song now.
Right, yeah,
Tony.
good time for a song. Well, I'm going to open up today with a dead set classic from the early 50s, The Platters, Only You. Yeah. And yes, that was just the Mamas and the Papas with California Dreamin' from the 1965. And now we're getting straight back into it with Beck and Jacqui. Go for it, girls.
Thank you very much. Good tunes you picked there, Tony. Thanks
you.
for that. Good music.
I pick good tunes all the time, but then go for it.
My next question for you, Jacqui, was could you tell us a bit about your career? Because I know that you've done quite a bit over the years and have had your fingers in some interesting areas.
Well, I started off as a physiotherapist in a large hospital in Sydney, and I was there for about 18 months, and then I went and did a locum at Burke Hospital, and I was the only physiotherapist.
Oh, wow.
Which was, it was a very interesting position to hold, because in the larger hospital, I'd actually been fortunate enough, I worked in rehabilitation and I worked in the paediatrics unit, but I also cycled through the medical and surgical and orthopaedic wards and the outpatients and all the rest of it. But I was very pleased that I had that paediatric experience, because when I was out at Burke, that was quite a large part of my workload was kids that had respiratory problems.
Oh.
but also somebody that unfortunately had an accident and become quadriplegic. He'd had his rehab in Sydney and now he was back in Burke Hospital. So that was one end, then there was the kids, and then there was everything else in between. So it was actually very interesting, and being the only physiotherapist there.
Wow, yeah, wow.
You had to really sort of think on your feet and also rely on your other staff. So I had a very good physio aide out there and she was really great and really helpful. And from there I was asked whether or not I'd consider going to the position at Dubbo in Lord's Hospital, which is the big rehab hospital there.
Yeah.
So I did take that on. That was interesting because I was the one physio over the 1.5 physio.
How'd that work?
But again, we just had a really, a very wide caseload. So I had, for example, at one stage there was quite a young child that had had a brain injury from a fall. There was another young man that was a quadriplegic. There was an older lady that had a stroke. There was an elderly ex-butcher who was hilarious because he used to sing out all the time and say, "Do your best, your very best, and do it every day. If you can't do any more, don't do any less." And we'd be going, no, you've got to be quiet. There's other people. He didn't let that bother him. But it just a very, very varied caseload. And what was great about that position was that the half a physio was an older physio. She was probably, well into her 50s by then. But she was really very innovative and very creative, kept right up to date with all of her physio, because we were all members of the Australian Physio Association. We'd go to courses, to improve our skills. And she was fabulous. She really, because I was such a young physio at that stage, but she really sort of taught me to think on my feet and to think outside the box about ways that we could treat multiple people at the same time. It's almost like stations in a gym program, but of course it was...
Yeah, because I suppose that would have exposed you to quite a lot of different sorts of injuries, conditions and a whole heap of things that you probably wouldn't have only ever focused on a couple in this.
So that was really interesting. And some years later, after I'd worked overseas, I came back. I ended up working at Western Suburbs Hospital in the rehab unit there. And that was a fantastic unit. Unfortunately, that hospital's been bulldozed quite some years ago, but it had a fabulous rehab unit and a big hydrotherapy pool. So I spent a lot of time in the pool doing hydrotherapy as well.
That would have been all right. In the pool for work.
I mean, it was great, but you do smell of chlorine a lot.
So true. So I suppose then, as you said before, then you got into the other areas with insurance and things, which led you...
Yeah. Well, I also, in the meantime, did a dip ed in adult education because I started teaching, and so I really wanted some structure, some way to structure the way that I was doing teaching and training, so I'd done quite a lot of that as well too.
Sounds like
then I did the research.
Jack of all trades.
It's just I've been working for a long time, Beck. You've got to keep it interesting.
Yes. No, it sounds like you've had a fabulous career and you've got to meet some lovely people in some areas that a lot of people don't tend not to want to go these days.
Yeah. Well, the interesting thing about rehab too, so especially once I moved away from being the physio and moved into a team, was it was fantastic at Western Suburbs. I had a great team, community nurses. We had some wonderful community nurses. They were just so clever and so experienced, and you'd work in with them like you might be treating somebody as an inpatient, then they'd be going home, so you'd be collaborating with the community nurses about what happens next when people go home.
Excellent.
But working with the occupational therapist and the speech therapist, we had a fabulous head of department. The doctor that we had, he was just wonderful. So
sounds like a really good experience.
Yeah, that was a really good unit to work in.
It sounds like maybe it should still be open. My next question for you was, were there any standout stories that stuck with you over the years, or anyone in particular besides the gentleman that used to sing?
Relevant, of course, yeah.
Oh, Gosh, a standout story. The problem is that so many of them stand out, to be honest, because you're working with people so closely and so collaboratively to work out what your goal's going to be and how you're going to get there. So you spend a lot of time with people over many, many weeks in a lot of cases. So especially if you're working with somebody that's had a brain injury or a stroke, you do, or spinal cord injury, you spend so much time with them. So a lot of them are standouts. I remember a lot lot of them.
A lot of funny moments by the sound of it. Yes, definitely. So I'll just flick over to you now, Tony, and if you'd like to play some more music, that would be great.
Just to break things up a bit. Okay, let's go back
Thank you.
Let's open up this little, I'll play this little thing right now. Have we heard, anyone out there heard of Jay and the Americans? Well, I've got Jay and the Americans now with Come a Little Bit Closer from the year 1987. More good stuff, hopefully. Yes, there's a bit of a hindsight thing there, a bit of the Skyhooks with Jukebox in Siberia from 1990. Even though it wasn't that year ago looking at it now, but I'm not sure, it's a long-lost little Aussie classic rock there.
Yeah, I love the Skyhooks.
And of course it was Skyhooks, that's right. And of course it was Red Simons as the guitarist. Do we all remember him from the show Hey Hey It's Saturday?
Yes.
And of course it was from the album The Latest and the Greatest. I'm not sure if that was a compilation album, but maybe it was a compilation. They just named it like that.
Yeah, maybe all their best hits. Because I don't remember his last name, but I remember the singer's name is Shirley.
Shirley?
Yeah.
Yes.
Okay.
And he had long curly hair. That's all I remember.
There you go. Anyway, let's get back into it.
We'll jump straight away in, yeah. So I'm here with Jacqui, and she's a researcher for those that are just tuning in. And we're going to ask a question now that's very close to Jackie's heart.
Let's not forget to include the thing. She's a researcher from the Australasian Research Centre, which is going to be referred to, pardon me, the Australasian Research Centre will be referred to as by the acronym AROC from now on, okay, for the rest of the show. Go for it. That's a little 2 cents worth I got to throw in, so go for it.
No worries, but I'm going to correct you, sorry. And because it's Australasian Rehabilitation Outcome Centre. And because it was a mouthful for me to try and wrap my head around.
I wrote it down, so thank you. Go for it.
All right. So my next question for you, Jacqui, is how does research impact rehabilitation models? Because I know you do a lot of work behind the scenes there.
Okay, so that is quite a broad question, but I would say that very generally, because AROC is an outcome centre and it provides those multiple reports that I referred to earlier to its member facilities, they also run workshops, and we used to run we still do, run day-long workshops for the public sector. So you might do all of Victorian hospitals over 2 days, and same for Sydney, and then 1 day in Adelaide, Perth and Northern Territory. I used to do that one by video because obviously they weren't going to fly me up to Darwin to do that one. But the whole idea is to present hospitals' rehabilitation services with their own data so they can see how they're tracking against the benchmark. And those benchmarks are not aspirational benchmarks, although those are sometimes used. So, you know, an aspirational benchmark might be where you say, we want all of our patients with this particular type of stroke to gain 20 points of functional independence measure score, and we want them to stay for, let's say, 14 days. That might be an aspirational benchmark, but the benchmarks that AROC uses is actually drawn from the data. So you're saying that for people that have had this type of stroke, that have this amount of function when they come to rehab, we would usually expect that they'll make about this much improvement and they'll stay for this long. And I always used to think that when I was a younger, less experienced physio, it would have been great to have those benchmarks, because one thing that people always want to know is how long will mum be in hospital for, as an example, and or how long will my son have to be in hospital?
So it just answers several of the lesser questions, yeah?
Well, it answers those things that you can use on a day-to-day basis when you're working with people and with their families, for example, because it's very stressful when you've got a family member in hospital, as of course I know you two both know very, very well. And one of the things that people will always want to know is, well, how long is this going to take?
Yes.
How much improvement are they likely to make?
Could we expect, yes.
Yeah, could we expect, that's right. So these sort of things, they don't say you will make this much improvement or you will stay that long, but they say...
It's indefinite.
As a guideline, this is what that would normally look like. And as you know, when people start their rehab program, they're actually assessed using the functional independence measure. And that's got 13 motor items. So it would look at, can you dress yourself, grooming, able to feed yourself, bathing, able to transfer to standing, how far can you walk, can you go up and down stairs, those sort of things. And it's got a couple of cognitive items as well.
Attached to it, yes.
Yeah. And so the idea is that you do that when people first come into rehab, and then at the end of their episode you do it again, and so you can see what the difference is between the start and finish scores.
How will they maintain certain key points in their head, yes?
Well, yes, for the cognitive,
yes.
But because I'm a physiotherapist, I tend to always default to, can you walk when you weren't able to walk? How far can you walk? Are you able to climb the stairs? Are you able to groom yourself, feed yourself, etc.?
Yeah, the daily... What are they called?
Activities of daily living.
The daily
ADLs,
routine.
Yes, that's right.
That's
They're actually referred. Those ones are referred to as instrumental activities of daily living. So the IADL.
Wow.
But the point about using the FIM is that everybody that uses it has to do the official training so that the data is as accurate and consistent as it can be, because there's no point in... you can't compare apples with apples if one hospital's using it this way and another hospital's using it that way. It has to be consistent so that you can look at the data and go, okay, we can trust this data to give us an overall picture of what's happening with these patients that fall into this particular category, because you're not comparing everybody with everybody, of course, because...
Not everybody has the same...
That's right.
Yes.
And it would be unreasonable to compare the functional gain and length of stay that somebody that had a planned total hip replacement, you can't compare that to somebody that's had a brain injury or a spinal cord injury that's, an accidental happening, and they're going to take a lot longer to recover, and you're not sure how much function will be regained, but you're sort of aiming for the maximal that you might expect.
Because if it was planned, then you would have a very independent acceptance of the whole mindset and be self-preparation, wouldn't you?
Well, yes, and I think that's a really good point, because when you are going to have a planned hip replacement or a knee replacement, and there's a lot, that's a very, very common procedure, of course, but you do have an expectation. You'll get some information from your orthopaedic surgeon if, in fact, you go to rehab at all as an inpatient, because often people do, outpatient or private, or somebody will come to your house depending on your circumstances. So that's a very different mindset. And you know that in 3 weeks you can expect that you can do X, and in 4 weeks you can do Y. And
you'll be at that level, yes.
Yeah, and at 6 months you're likely to have extremely good function. You'll have good function well before that, but I'm just using it as an example. Whereas if you've had, as we say, a brain injury, it might look quite different.
I'm going to throw one in there that I haven't pre-given you, because I know that you do some stuff with different facilities and things like that, based on the way that they want to tell us something, they want to find out a bit more about it. So you actually do research projects with them.
Oh, yes. So some of the research, we do independent research as well as all of the benchmarking. AROC also, as I say, it's got this fabulous data set. So clinicians can apply to use that data set. It goes through a rigorous process, and they have to talk to the fabulous data manager, Tara.
Yeah, she's wonderful.
Yeah. And I mean, Tara's been with AROC since inception, so more than 20 years now.
So she knows her onions.
She knows the data inside out and upside down, and she's a very good researcher. So she will go through, if you had a question and you think, well, I'd like to use the AROC data for the past 20 years to look at this particular issue. For example, do people that have comorbidities take longer to get home after their rehab?
You'll have to just briefly explain that term. I haven't heard of that.
Well, so a comorbidity
yes.
is a pre-existing condition. So you're going into hospital for treatment for another condition, but you have a pre-existing condition, and that might be, for example, you may, for example, have had an amputation 30 years ago.
Yes.
Is that going to impact on your rehabilitation now that you've had a stroke? So you're looking at that type of thing. Does that make sense?
No, I'm trying to put that in my own sort of mindset now, because I know if something happened to me, everything has to come back to the fact that I have a traumatic brain injury. So would that be a comorbidity?
Yeah, well, if you would say you were going to go and have a knee replacement, people might record that as a comorbidity, because they might, in discussion with you, they're thinking, well, perhaps this will impact on his short-term memory, so that when I'm talking to him about what I want him to do, I need to make sure that I come back and remind him. Does that make sense?
So a pre-existing condition.
Yeah.
I was about to say that you took the words right out of my mouth.
Yeah, so it's a pre-existing.
I'm sorry, as soon as you said with the term comorbidity, I'm thinking straight away, does that mean I've died with someone else?
No.
Comorbid, okay, yeah.
I know, it does sound like that, but no, a comorbidity is a pre-existing condition. That's the way to
I'll have to write that down.
Yeah.
But imagine if somebody wanted to use the data to look at that, then they need to talk to Tara, and she'd talk them through to really establish, well, what is your research question. They really want to refine the research question, and she needs to make sure that the data can actually go towards answering your question, because there's no point in doing all of this work if the data isn't the right sort of data to answer your question. And then the work that I've most recently been doing is looking at patient-reported measures. So that's really about, and there's a big shift towards that in the whole health sector, is the patient voice, the patient feedback. So it's not just feedback, it's structured feedback. And
you see a little bit from the other side, not just the clinicians.
So, for example, somebody may have gone through their rehabilitation, and as the physio think, oh, well, that's great, they're up and walking and they can do stairs, that's good. But the patient may feel that their pain levels weren't managed well, and that you didn't communicate to them very clearly when you were talking about their goals, and you didn't do collaborative goal setting. You just told them what you were going to do.
Yes. I understand that one all too well.
Face, yes.
Well, you're working. The whole idea is that you're working with the patient.
Yes, you're not ordering them around.
Yeah, you're not rehabbing. You're not rehabbing somebody. The pair of you are working together to establish your rehab goals and to work out what the steps are to get there. My most recent piece of research was we were looking at clinician and patient attitudes toward patient-reported measures to see, because there's no point in having the best measure on earth if nobody wants to use it, or it takes too much time, or it asks questions that aren't helpful. So we were doing some qualitative research with clinicians and patients to look at that.
Lovely work.
Wow. Well,
we're going to break things up now. We'll just play a couple songs, then we'll see how we go from there. I'm going to hear for you, everybody. It's a Steely Dan with Dirty Work from 1972 from the hit album Can't Buy a Thrill. We all love this one, yeah. Yes, that was just the classic Aussie dudes, Mondo Rock, with Come Said the Boy from the 1983. And do we have anything more to go?
Yeah, we've got one more. We're gonna get a little bit personal now, Jacqui.
Now remember, no personal details like our mobile phone number, your bank details.
Oh, no, none of those. We're just talking about your hobby.
Well, where's the fun in that then? Come on. Obviously got her giggling to it, so okay. Hobbies, there we go.
It's good stuff. So could you tell us a hobby, something you like to do when you're not in that space having to be professional in?
Beck, I'd like to be able to tell you something really interesting. However, what I'm going to tell you is that I've been singing with chamber choirs for the last 15 years.
Wow.
Oh, cool.
It's like opera.
No, we don't do opera. We do more sort of ye oldie Latin music.
Ye old type.
Yeah. So it has that structure, the sopranos, the altos, the tenors and the basses.
So which vocal range do you slip into?
I sing alto with one choir and tenor with another choir, but I prefer the tenor because it's more within my vocal range. Actually, I mean, the truth of the matter is I've got a really limited vocal range, so anywhere where I can find 3 notes that I can hit,
stick to them.
That's mine.
Oh, excellent. So, you had mentioned that you were going to be doing something on the Queen's Long Weekend.
Yes, I'm really looking forward to it. I have done it quite a few times before. So I used to sing with the Sydney Philharmonia, which was just absolutely wonderful because you get to sing in the Opera House. So
wow,
that is the only way I was ever going to get to sing in the Opera House.
That's not bad.
And I had enough insight to recognise that, Beck. So I thought, oh, well.
Well done.
But it can be. It's just a fabulous opportunity. They have an orchestra and they also have soloists. And so I've been busy preparing for this long weekend. We're going to do, it's a piece by Sir Carl Jenkins, who's the royal composer. He composed the music for King Charles's coronation. Ooh. Anyway.
La-di-da.
So this particular piece is called A Mass for Peace, and it consists of all of these different parts. It's stunningly beautiful. I'd urge people that have the slightest interest to go on YouTube. There's lots of recordings of it, but it's very beautiful. So what we do on the long weekend is we've had the scores and all of the learning resources I think I've had them since December. Yeah. And then on the Saturday, I think there is now 1,000 choristers. So it's not just Australia, it's Australia-wide and overseas.
Is that what you call someone who sings in a choral choir? A chorister. Wow.
We'll learn something new today, Tony.
More than one thing.
Definitely.
Yeah.
Anyway, so it's going to be 1,000 choristers. Apparently it's the biggest choir ever. And the thing is that the conductor, Brett Waymark, is he is fabulous. Anybody that can get 1,000 people to sing really quietly and beautifully when they need
control
to
the tone of their voice.
Control, yes, and
to draw you in.
Yeah. So
I get it.
Some friends of mine said, we'll have to get tickets. And I went, 1,000 people are singing it. I don't think there's any seats left in the Opera House. But anyway, we rehearse all day Saturday and Sunday morning, and then on Sunday afternoon we actually do the public concert. So that'll be fantastic.
Exciting for you.
Sorry, one sec. So are you trying to say that it's a sold-out event?
Look, I don't know if it is, but I'm imagining it is. And as I say, if it's sold out, it would just be all of us choristers buying up and
doing your thing, all right.
Taking up those places. But yeah, it's a fabulous opportunity. I've just, as I say, I would never have got to sing at the Opera House in anybody's terms. So this is the only way I could do it, so I've done it. It's
excellent.
Great.
Oh, that sounds really great. I'm excited for
Impressed.
you. Yeah, that would be great. So I suppose we'll wrap it up now then today, Jacqui. Well, I don't know if our listeners have learnt a lot of new information they would not have otherwise known about. But I've had a great time talking with you today, and we might even get you back in a couple of months to tell us some more about different things.
I would love to, Beck. Thanks so much for having me, and thanks, Tony.
Beautiful. Thank you very much. See, I've learned something definitely too. The term comorbidity has nothing to do with you actually passing away. So
no.
Don't laugh. For a long time I thought, why is it called a comorbidity? I admit I was a lot younger.
Yeah.
And I used to think comorbidity, exactly what you did.
Yeah.
I did learn eventually.
Wait, so do you know the reason why it's called dead morbidity?
No, morbidity doesn't actually mean death. It just means...
inactive?
No. It means disease or damage.
Right.
Yeah.
Oh, there you go.
So
something
a disease or damage you can live with.
Yes.
Yes, right.
Yeah.
So that's why it's you're living with a disease or damage. I get it now.
Yeah.
Thank you very much for explaining that. I'll no longer think.
I hope my linguist nephew doesn't hear this and say, well, actually, Jacqui.
Yeah. Well, you should
I
say
think
like this.
you'll find.
You're not correct.
Yes.
So, yes, thank you very much again. I really appreciated having a chat with you this morning, and I'll pass it over to you, Tony. Thank you to all our listeners. Have a great afternoon.
Thank you very much there, Jacqui. And I'm afraid it's come to the end of the show, hasn't it?
It has. It's about that time.
Yes.
Thank you very much to all our listeners today.
Yes,
I hope that everyone's enjoyed hearing about the research side of things, something we don't really hear
The
about.
behind the scenes and what makes living and, I suppose, helping you out from the hospital's point of view makes it more seamless and effortless seems. But yes, now we must say goodbye. So
Good afternoon to everyone. Have a great afternoon, everyone. Thanks for listening, and we'll be back with you next week.
and thank you very much there,
Jacqui?
Jacqui. Having several
You're
lapses
right.
of memory there, but yes.
Thank you, my pleasure. Thanks for having me. And Beck, congratulations on your recent award for people that don't know about it.
Oh, thank you. I got the 2024 Courage Award with the National Stroke Award. So.
Yeah, no, that was fantastic. Congratulations.